Hello and good morning and good afternoon. My name is Tracy Cook and I'm with Zach Healthcare Communications. I'd like to show our audience today how to send in your questions, which our speaker will answer as many as possible at the end of the webinar. Please type your questions into the questions box. You can also download the handout from the handout section of the GoToWebinar control panel. Our moderator today is Christina Davis. Christina earned her BSN and MSN degrees from the University of Miami in Coral Gables, Florida. She has an extensive background in GI digestive disorders in both the treatment and diagnosis of GI and liver disorders. Currently, Christina serves as an adjunct professor at Franklin University and United States University. Her experience also includes clinical research on infection-related topics conducted through the NIH and FDA. Christina, welcome.
Good morning and good afternoon. Thank you, Tracy, for that very kind introduction. The title of today's webinar is Incorporating Chicago 4.0 Protocol into Clinical Practice for Esophageal Manometry. Speaking today on this very important topic is Allison Becker. Allison is a registered nurse from Cleveland, Ohio, who graduated from Xavier University in Cincinnati, Ohio in 2013 with her bachelor's in nursing. She started her career at the Cleveland Clinic Foundation on a medical surgical floor focused on post-op patients after colorectal surgery. She then worked at NYU Center for Esophageal Health as the Director of Motility Nursing, where she performed esophageal motility testing and provided direct patient care, while completing her Master's of Science at NYU Rory Myers School of Nursing with a focus in nursing education. Allison is currently working again at Cleveland Clinic Foundation in an endoscopy suite. The speaker disclosed the following financial relationships: Speakers Bureau for Medtronic. The opinions expressed are the personal opinions of the speaker and do not reflect the opinions or views of the sponsor Medtronic or Saks Healthcare Communications. This activity has been approved for one contact hour for nurses. A link to obtain your certificate will be available at the end of the webinar. The accreditation statement is below, and support for this activity has been provided by Medtronic. With that, I'm going to pass it over to Allison. Thank you.
Thank you so much. I'm excited to be here today and looking forward to the questions at the end when we talk about, after we've talked about Chicago 4. Okay, so because the world of esophageal motility is kind of a very niche specialty, I just wanted to do a bit of a refresher about what we're actually evaluating with esophageal manometry and then therefore Chicago 4.0. Okay. So the esophagus is a muscular tube-like structure responsible for transporting swallowed food and liquid from the pharynx down into the stomach. We have three main portions of the esophagus to consider when evaluating this organ. First, the upper esophageal sphincter. I'll be referring to it as UES in this presentation. So this opens in a typical anatomy upon a patient's conscious swallow, and it then opens to allow the passage of food into the esophagus from the pharynx. So it's intrinsically connected to the complex swallowing mechanism in the throat. Typically when we're doing a manometric evaluation, we are not considering the UES, but it is visualized during testing. The body of the esophagus. So fun fact, the esophagus is the only organ in the body to contain both striated and smooth muscle. And in a healthy person, it will propel the swallowed food bolus down into a peristaltic wave. So this all again happens in the body of the esophagus. Then finally, we have the lower esophageal sphincter, also known as the LES or the EGJ. So this sphincter kind of gradually opens during the initiation of the swallow and remains open during the push of the peristaltic wave of the food bolus. So this is meant to stay closed at baseline to prevent stomach contents from being refluxed into the esophageal body, and then of course open during swallowing. It's referred to as a junction as in that term EGJ because we want to encompass the involvement of the diaphragm's influence in the area because the diaphragm kind of pinches in on the sides of the sphincter and it helps to keep that area closed at rest. So this is one reason that if a patient has a hiatal or diaphragmatic hernia, basically the LES no longer has that anchor. So it no longer is really considered that junction because of the lack of diaphragmatic involvement, because the stomach is herniating up into the chest cavity. So then the process of peristalsis. In the body of the esophagus, there are two different types of peristalsis that occur. Primary peristalsis is mediated by the swallowing reflex. So this is what we're evaluating during manometry. Basically, we just want to see how strong that push or propelling of food down into the stomach is occurring. Secondary peristalsis is not associated with a contraction from the pharynx or an initiated swallow by the patient. It's actually thought to be a protective mechanism to push reflux stomach contents. Like if when we're sleeping at night and laying flat, if we reflux stomach contents up, the assumption is that secondary peristalsis would then push that back down. This can be visualized on manometry, but we're not actually measuring this in the interpretation. So how does this peristalsis or push occur in the esophagus? So kind of hitting on the theme of the esophagus, we have also two sets of, because there's two sets of muscle, there's control from the two nervous systems involved in muscular contraction. The upper third of the esophagus contains striated muscle activated by the central nervous system. Then there is a bit of a transition zone of the esophagus where mixed muscle types of both striated and smooth muscle lie. And then the remainder of the esophagus, and then of course the remainder of the GI tract, is smooth muscle only, and this is controlled by the peripheral nervous system. So if you know anything about esophageal manometry, you know it's nobody's favorite test. So why are we putting patients through this? Why are we ordering it? What are the indications? And what exactly is a nurse's role in doing so? So I've listed here the main indications for manometry. They include difficulty swallowing, of course, or dysphagia, aiding the placement of a pH catheter, pre-op testing for anti-reflux surgery, such as an fundoplication, evaluation of non-cardiac chest pain after PPIs have been trialed to rule out, reflux causing that chest pain. It's often a last resort for patients because of its discomfort, and people are very anxious around the scheduling of this test. So usually, they have a pretty extensive workup by the time they're reaching a motility clinic. In the clinic that I worked for some time, NYU, we had requested patients complete either a barium esophagram or swallowing X-ray, or an endoscopy within a year of the manometry appointment. This is just because we want to make sure that we're placing the catheter safely. It does not have a camera associated to it, so if there are any structural abnormalities of the esophagus that would make placement unsafe or perforation more likely to occur, although it's extremely, extremely rare, we want to make sure that this is an appropriate candidate. So that is an important method when considering this test. Okay, so when it comes to the technical care for a manometry catheter and setup and so forth, the motility team at the GI clinic is going to be usually responsible for that. Because the test is so challenging for patients, we always found it very important to be prepared, have all of your supplies ready at hand to minimize the amount of time that the catheter is going to be actually in the patient's body. So these photos include a setup of our equipment from when I worked at NYU. Essentially, I have a 10 ml syringe, a cup of saline, a cup of sterile water, lubricant, and tape at the ready before the patient even enters the room for seamless placement and performance of the manometry. Our clinic always used the Medtronic Nanoscan software and the Medtronic esophageal manometry catheters. So the software, I can't speak to other softwares from other companies, but the Medtronic software very seamlessly kind of guides you through calibrating the catheter prior to placement, making sure all the sensors are functioning properly, before we put the catheter in, just in case there are indeed any structural problems with the catheter that could cause an inaccurate reading during the study. The sensors on the manometry catheter are extremely delicate. We always teach our staff to handle these catheters with great care, so that they can preserve their working life and not cause, consistent damage to the sensors. When we're calibrating these catheters, we do so in a vacuum chamber. Air is released inside to test the measure of the pressure on the sensors of the catheter and make sure that they're all feeling the same pressures and feeling that pressures appropriately. You can see on the monitor within the photo of our setup, there's color pressures that looks like a rainbow. It's a nice straight column. This is what a properly calibrated catheter would look like. If there was any issues with some of the sensors, there would be impingements in that area of the catheter where the sensor was malfunctioning on that column of pressure. But since this is all straight up and down, we know that it was functioning properly. So if there is indeed an issue with calibration, there's a number of ways to troubleshoot the device to isolate the issue. The Medtronic software tells you which sensors are failing after the catheter doesn't calibrate. So then you can either block that sensor or speak to the physician and talk to them about how comfortable they are with using a blocked sensor during the study. One should also check that the vacuum calibration chamber is completely sealed. Sometimes if the seal is not on tight enough or there's an air leak, it will fail calibration for that reason. So going through your attachments, please make sure that there's no air leaks and everything is properly connected. Also, another reason people receive errors for calibration is they had the incorrect, they chose an incorrect catheter to match up with the software. If you have multiple catheters in your clinic, if you try to calibrate, if you choose a catheter on the system that does not match with the actual catheter that's plugged into the program, it's going to malfunction. So it's important to double check that as well. If the catheter didn't calibrate despite all these points, you can try what's called a tune system on the Medtronic system. This basically provides a gentle reset of all the sensors in the calibration chamber. It's something that takes a couple of minutes, so sometimes it can put you a little behind if you are trying to, get another patient in the room. And then, so if after that it's still not calibrating, calling technical support would be the next recommended step to further discuss, troubleshooting and if the catheter does indeed need to be replaced. I mentioned in vivo calibration on this slide. This is essentially a function that's recommended to be performed weekly so that the catheters can recognize a typical human body temperature to allow for thermal compensations that are picked up by the catheter while it is indeed in the body. So the Medtronic Nanoscan software actually does automatically apply this reading when the catheter is removed from the patient, but it's still, so it's kind of, it's not exactly required anymore. This used to not be something that the software included, but it is important to still perform in vivo weekly in case this function is not working for whatever reason. It can be a little cumbersome, but again, it is still something that is important and recommended. Okay, so nurses are typically the face of the manometry study. There are oftentimes where physicians will not even be coming into the room for the study itself. It'll be the nurse one-on-one with the patient, getting them through this challenging test. Usually it requires a lot of patience and empathy to get people to not only, complete the test, but also come to the appointment. It's very daunting to think about an NG tube placement. What we always did at NYU was, we would, if there was a direct referral where one of our physicians didn't explain the test to the patient directly, we will always call those patients and talk them through, what to expect. We would always reassure them that placement's the worst part. It only takes a few seconds to get down. Then your body's in kind of a shock that something has entered from the nose down into the stomach. So it takes a little bit to acclimate. You may gag, you may vomit. It's okay. We're here. We're going to help you get through it. We always just kind of, have them do deep breathing, try and relax. We usually dim the lights, maybe put some music on, try to set as much of a calming environment as we possibly can. Because the patient has to control their swallowing to complete manometry, this can at times take a little while. So, it's challenging to control your swallows when you have a foreign object in your throat. Something that is a natural response. We want to just swallow because we feel like there's something there that we need to swallow down. So, again, just giving them their time to acclimate, not rushing them, but also, reassure them, give them the confidence that they can complete it, and also try to keep everything moving so you can, get on with your day and continue with your next patient and stay on time. Using your nursing judgment and ensuring that the manometry placement is accurate is also an important part of testing. Because if the catheter is not far enough and we don't have a visualization of the EGJ, I'll go through that a little bit more in our next few slides. That would be, would cause an issue with our, final read. We don't want to get a patient through this and then the physician reviews the final read of the study and says, listen, this was not a correct placement. They have to come back and do this again. They will not be very happy. So definitely using your critical thinking, critical assessment skills is important to ensure that we are doing the best by our patients. We always at NYU stood by that educating patients prior to the procedure is crucial. I've had some, colleagues say that, oh, we really just don't tell them the details of the test before they come in at our clinic, because then they're less likely to come if they know that it's really uncomfortable. Again, I'm more of the honesty is the best policy. If a patient feels like, they were duped into coming or that they were, given, told the truth and treated like, a fellow adult as to what the test entails, they're going to be less likely to complete the test when they realize how uncomfortable it is. And it's going to give them a poor taste about their care because they're going to feel lied to. So certainly, we spent a lot of time talking to patients and giving them resources before the appointment to make sure that they're willing and understanding to go through with the test. Regarding pain management during the procedure, there's mixed data from studies done showing if pain management really makes a difference during manometry or not. At NYU, we always chose to use pain management because in our mind, even if it's placebo and it's not like, it's mentally something that we're trying to do to make them more comfortable. We would use a benzocaine gel into the nares, and then a benzocaine throat spray to numb the back of the throat. But we also still wanted to make sure the patient was aware during our education talks that the numbing is not going to take away all of their discomfort, unfortunately. Okay, so now that we've discussed, what we're doing manometry for, nursing's role, we'll go through the basics of performing manometry before we discuss the Chicago Classification 4.0 editions. Okay, so once we get the catheter from the nose, down the back of the throat, down the esophagus, and then into that tip of the stomach, we are going to first assess on the screen to make sure that we're in the right location. Like I said before, if the catheter did not pass through the LES, oftentimes it will not be a correct read and we will need to repeat the test. So it's very, very important that we see that the catheter has passed through that point. So this is an example of a correct placement on the screen. So, typically you're going to be seeing two bands of pressure at the top and the bottom of the screen with a bunch of blue in the center when the patient is not swallowing and is at rest. So those two bands of color represent the UES and the LES, also known as the EGJ. To ensure correct placement, we had patients take 3 deep breaths to allow visualization of the diaphragm. So when they take these deep breaths, you see that there's these like little pinches of yellow. The colors on the screen represent different pressures. So cooler colors are 0 pressure. So the blue in the middle being completely, that's the patient, that's the catheter not feeling anything around it. The bands on the top and the bottom are the catheter feeling the pressures of the UES and the EGJ. So when you see that, we see green for the most part on the bottom, but then little pinches of yellow, that's the catheter feeling the diaphragm pinching, so putting more pressure on, so the color is getting warmer. So you can see right here, there is an example of a swallow. So the swallow, you can see there's some red here. That's again, that increased pressure contraction. And the UES is opening. So you can see that this area is now a little dark blue. And then there's a series of warm colors that represents the peristaltic push of the sensors on the catheter, feeling the muscles contracting as they travel down it. So once the catheter is confirmed in an appropriate place, we then lay the patient back at an angle less than 45 degrees. So we want to essentially have them be supine for the procedure. At NYU, we did not put them fully flat. Some clinics do it that way. Again, less than 45 degrees of an angle. So mostly, laid back is appropriate. After the patient's in a supine position, we then try to get them to relax, again, do some deep breathing. Usually this is that period of acclimation where, they're just getting used to the catheter being there. We try to get them to avoid swallowing for a 30-second period. This is the first, this is the landmark ID. It's important because we need to obtain the resting pressure of the lower esophageal sphincter without the influence of a swallow. So it's a very important part of the study when included in the interpretation, because the physician will refer back to the resting pressure. Because we want to understand how effective the sphincter is functioning during swallows, such as, is it relaxing when it's supposed to, and how loose is it at baseline? Okay, after the 30-second period of no swallowing, then the nurse will guide the patient through 10 swallows in that supine position. It's important that the patient only swallows once because, at least again for the Medtronic Manoscan software, the software only analyzes one swallow at a time. So if you have a second swallow come right after, the software will be confused and it will not be able to give you an accurate reading. It's also crucial that the EGJ completely relaxes to baseline after the swallow is complete. So you can see it's kind of a little more yellow right here. There's a little bit of a delayed contraction of the EGJ after a swallow, and then it slowly loosens back to baseline after some time. Some patients, it takes a little longer than others, so we always, want to make sure that we're seeing the sphincter relax back to baseline. The software for Medtronic will automatically wait a full 30 seconds between each swallows when you initiate a swallow on the software. You can't end it earlier if you do see that it is back to baseline, but if you want to be extra cautious, you can always just wait that full 30 seconds. So this is a visualization of a healthy swallow during manometry. I touched on it in the prior slide, but you can see the UES and the EGJ is relaxing, and a mixture of cool and warm colors, and the peristaltic wave of both striated and smooth muscle, indicating that there's a good adequate push of the ingested liquid. So prior to the implementation of Chicago 4.0, these 10 swallows in the supine position that was all of manometry that was done. So that was Chicago version 3.0. It was a much faster study, but there are some glaring shortcomings that could even lead to poor outcomes and unnecessary procedures for patients in how these studies were being interpreted based on just those 10 supine swallows alone. So that's why, the team of experts came together and discussed how we can address these shortcomings with a more thorough investigation. Okay. Oh, before we go into that, one quick thing. This is an example of a curled catheter. So sometimes during placement, the catheter can curl up on itself. And then you can see this butterfly pattern on the screen. This is essentially the catheter feeling the same pressure, but it's curled upright, so you can see a mirror image. So if you see this, you need to readjust. You need to pull back on your catheter and then reinsert. We usually have the patient drinking water during insertion, putting their chin down, sometimes even standing them up can change the pressures to get the catheter down. So this is an example of if you saw this and you proceeded with the study, this patient would need to redo the test. So very important. Okay, now we'll talk about how to incorporate the Chicago 4.0 protocol and why we added these additions. So on this slide, I've included some measurements that are assessed on manometry. I'm not going to get into the specific details of these definitions. They're very technical, but it's important, I think, to remember what manometry is assessing when we're performing the study so that we can indeed get the best possible read for a patient. So understanding kind of a baseline of what we're going to be looking at is crucial. So IRP, or integrated relaxation pressure, is basically how well the EGJ is relaxing. DCI, or distal contractile vigor, or distal contractile integral, is basically how strong the contractions are in the body of the esophagus. And distal latency, or DL, is the amount of time between the initiation of the swallow at the UES when it relaxes to the peristaltic wave occurring. Again, we have here the very basics of interpretation listed out. The physician's looking for how tight the EGJ is and how well it relaxes during a swallow. whether or not there's peristalsis in the body of the esophagus, if the contractions are rapid, and if the contractions are generating an overly robust pressure. Sometimes it's very, very strong. And you see a lot of, reds and purples rather than just like a mix of oranges and a little bit of red and yellow like we see here. A manometry procedure with Chicago 4.0 includes the basic resting pressure and 10 supine swallows, just like we had discussed. Then the additional maneuvers to address the shortcomings of solely doing those 10 supine swallows are listed here. Like I said, it does lengthen the time of the procedure, but these additions are going to help clarify diagnoses and prevent misdiagnosis of motility disorders. So this slide is the standard protocol that our clinic uses for Chicago 4, as it was published in the paper that originally introduced the topic. So just like we had gone over, the patient starts in the supine position, completes the resting pressure period, 30 seconds of no swallowing, and then completes the 10 supine swallows. Next, for the first edition, we do a multiple rapid swallow sequence up to 3 times. After that, the patient is then brought into the upright position, and in this position, they do 5 wet swallows, and then followed by, and finally, a rapid drink challenge. So I'm going to go over the multiple rapid swallows, the 5 upright wet swallows, and the rapid drink challenge in the next few slides. At NYU, we did not utilize the additional maneuvers listed on the other half of the slide. They are, of course, available to implement if a physician sees fit, but it's not something that our physicians felt were really relevant to diagnoses. Every once in a while, maybe we would add one, but our typical protocol did not include these. Okay, so first we'll go over the multiple rapid swallow sequence. So this is an important way to measure what's called peristaltic reserve. We kind of look at this as a stress test for the esophagus. So when we instruct patients to swallow multiple times in a row, we would expect to see a very robust contraction afterwards. So, you can see in comparison here, we have the one single swallow, looks pretty typical with, some yellows, a little bit of red, and even a little purple there. So this person had a good peristaltic push. But then after they swallow 5 times in a row, we see a lot of purple. We see a very robust, vigorous contraction. So, we wouldn't always expect to see this high of contractions, but maybe, if a patient had very weak peristalsis during their study, we would expect to see just a normal contraction after the multiple rapid swallow sequence. This is important to consider in preparation for anti-reflux surgery. So if a patient is considering a fundoplication, we need to make sure that their peristaltic wave has enough reserve strength to push food through a tightened EGJ. Because right now, if it was wide open and there was no push, that patient, if it was tightened down there, could wake up with dysphagia. So we're avoiding some complications there. And we're also looking at how well the EGJ is relaxing. If it's not relaxing properly, it could cause some abnormal pressures in the body of the esophagus, where we should see like mostly dark blue, 0 pressure during multiple swallows in a row. So I had mentioned before, we usually do up to 3 of these. If the patient has a good, robust response on the first multiple rapid swallow sequence, then we move on to the next part of the protocol. We give them up to 3 times because sometimes, they could have a response from one sequence to the other. And we want to give them that chance to see if they do have that peristaltic reserve. Again, we do leave them supine in this part, so this can be a challenging aspect to swallow multiple times in a row while supine. But it is the most thorough investigation for this topic. Okay, so I'm actually going to skip ahead to the upright swallows first. My slides got a little jumbled, and then we'll go back to the rapid drink challenge because that's the final part of the test. So after the multiple rapid swallow sequence, we then bring the patient upright, so at a 90-degree angle in the bed to essentially what we're looking for with upright swallows is correcting any artifact that can misdiagnose what we call an EGJ outflow obstruction. So when the patient is laying supine, which is an important part of esophageal manometry, the aorta or other errant vascular pressures can make it look like the EGJ is not relaxing as it should. So like I said, in my earlier slides, when the EGJ relaxes, we see, it go from like a greenish yellowish to like a lighter blue, indicating that, that area, that sphincter is opening. Sometimes the aorta or other vasculature can keep that area in a little bit of a yellow, yellowish green, and make it look like that's not really the case. If we sit the patient upright and the catheter is no longer pressing on the aorta or feeling, the heart rate, it's just hanging in the esophagus. It's no longer feeling those errant pressures. So that's why we do the upright swallows. If we see that this LES is still not relaxing in the upright position, then we know that this is true pathology. But we saw a lot of patients that were being misdiagnosed with that condition, EGJ outflow obstruction or EGJOO. And the treatment for that is either a pneumatic dilation or multiple serial dilations, certain medications, or even a POEM procedure, which involves cutting of that muscle. So those are sometimes permanent interventions done to someone who did not maybe even have a pathology to begin with. So very important to perform the upright swallows during the manometry. Okay, so after the 5 upright swallows, we then leave the patient in the upright position to do the rapid drink challenge. So in this portion of the protocol, the patient drinks up to 200 mLs of regular water through a straw at as rapid of a pace as they can tolerate. This, again, similar to the multiple rapid swallow sequence, we're looking for adequate relaxation of the lower esophageal sphincter. And we're trying to understand if there's a short DL or distal latency period, meaning is a peristaltic wave trying to occur despite another swallow rapidly coming after it. So when a patient is drinking rapidly, we should not see a lot of attempted peristaltic waves or continued pressure of the EGJ. We should see basically like a wall of dark blue. So we should see complete and total relaxation of both the sphincter and of the esophageal body because the patient's constantly drinking, triggering, like the start of a swallow over and over again. If there are abnormal contractions, this could indicate that the EGJ is not relaxing properly. This maneuver helps a lot with the diagnosis of spasm and, again, EGJ outflow obstruction. Okay, so as nurses, when we implement Chicago 4 to our manometry practice, it's key that we understand why we're performing these additional maneuvers, because it's like I said, it lengthens the time of the procedure. So we have to understand for our own sake and for our patient's sake, if they ask about why are they having me do all these crazy things going up and down and back and forth and swallowing and not swallowing. You may logistically have to lengthen your appointment slots if you add these implementations. We saw at least, 5 to 10 minutes, depending on the patient, sometimes longer, to complete the manometry and stay on time with the rest of your day with your patient load. Also, you need to be sure to have enough supplies to complete the protocol, like enough water to do the rapid drink challenge, enough saline to do the additional maneuvers, and so forth and so on. So I hope they've helped you to understand why these additional maneuvers are important in providing quality studies for these patients who are already going an extremely uncomfortable test. I do have a few more resources that you can access if you have some more questions or wanted to show colleagues that were not able to attend this webinar. So I did a talk on this same topic a couple of years ago for SACS Communications. It's in the archived webinar at the first link here on this slide. I also, in my partnership with Medtronic, have been able to provide some helpful resources on their education website called Medtronic Academy. In the endoscopy section, I'm going to have a couple of slides later on that kind of show you how to navigate that website. I actually did a video live with a patient of the Chicago 4 protocol. So if you wanted to see it in action, you could go there, and I'll again show you that in just a moment. If you do not use the Medtronic system in your clinic, contacting your whatever company you do use, contacting their sales rep is always a good way to learn more about it. They can connect you with resources specific to your equipment and help you troubleshoot a lot of the time. They're an invaluable resource. You should really get to know them well. And usually they, come by and check on you and make sure everything is, going as planned. Of course, the Chicago 4.0 actual, protocol paper is an excellent resource to, really understand the nitty-gritty technical review on the protocol. It's obviously very long and very filled with medical jargon. So, if it's a little difficult to digest, that's understandable, but certainly a good resource to have as well. Also, any number of, GI-focused conferences usually have a motility discussion, so you can understand a little bit more there by attending those. Some common ones are SGNA for nurses. I actually did this same talk at the SGNA conference earlier this year. ACG conference, DDW conference, or ANMS conferences and societies are also, great educational tools for you to look into. So I just have on this slide a QR code that you can access Medtronic Academy. There's more than simply just manometry. It's a lot of GI and endoscopy specialty education as well. So one of the reasons that I couldn't actually show you the video of me performing the manometry on a patient is because the patient signed consent that you could view her face during the procedure, and NYU was unsure of the legal implications because she was an NYU patient, and we didn't want to, have any HIPAA or privacy violations. So they needed the video to be on a password protected site. So you can access the Medtronic Academy without paying for it. You can just create an account and access those resources. So this is the video. This is what the main video page looks like for the manometry system. And then I just have a brief little video here that kind of, goes through the clicks to get to the Chicago 4.0 protocol video that I filmed. So you can see, there's a pre-survey, case files, and then that video that's down there. There's a lot of other, talking about the measurements, and then there's that final video down there performed by me and the physician that I worked with at NYU, Dr. Abraham Khan, who is one of the authors of the Chicago 4.0 protocol. Okay, so that about sums up my talk today. I'm going to hand things back over to Christina to go over some questions.
Thank you so much, Allison. All right, this educational activity has been approved for 1 contact hour. To obtain your CE credits, you'll go to www.saxtesting.com/INIT. You're going to register at the site, complete the evaluation, and upon successful completion, you'll be able to print your certificate of completion. And the archive or on-demand version is available at www.initiatives-patientsafety.org. You'll receive an email when it's available, and the on-demand version has been accredited for physicians and nurses. And with that, let's go ahead and get into some questions. We got a lot of questions, so let's go through a few. To start off, our audience wants to know, why are the first 10 swallows completed in the supine position during the manometry?
Yeah, that's a great question. So similar to the multiple rapid swallow sequence, the supine position allows for the esophagus to be, a little bit under stress. When we're sitting upright and swallowing, gravity can do a lot of the work. So we don't really need a good peristaltic push, and obviously patients are, not ever swallowing in a back reclined position typically. So supining them helps to, see really their baseline level of peristaltic reserve and how good of a push they are generating when swallowing, without just the patient relying on gravity to allow the contents to move down.
Sure, that makes sense. Well, thank you. Is the Chicago 4.0 protocol ever not appropriate for a patient for an esophageal manometry?
Occasionally, yes. If there's ever a patient who, for example, has a history of stroke and has pharyngeal dysphagia, we would not supinate them. So they would not be a good candidate for the Chicago 4.0 protocol. We could still get 10 upright swallows and assess the general peristalsis there. So it wouldn't be a complete 4.0 protocol, but we would be able to gather some information. We also wouldn't supinate someone who has a prior surgically treated LES for a condition like achalasia. So
Sure.
Conditions like achalasia are when the LES or EGJ is too tight and not relaxing, and the treatment for that is cutting that muscle. So if that muscle is cut, it allows for a lot of free flow of reflux stomach contents and could be an increased risk for aspiration. So we do not supinate those patients as well.
Absolutely, that makes sense. Okay, thanks. If the manometry study is a direct placement, how long after the EGD do you wait to do the manometry study, or do you need to wait?
So are you saying if they're, is there any way you could get some clarification on that? Like if they're placing it during the endoscopy?
Correct, I think that's what they're asking. Yes.
Gotcha. Okay. So, and we did not do that in my practice. I think we maybe did it for one patient, but there's a few reasons why we did not do that in our practice. One being it's logistically challenging because you have to put the manometry in while they're under, and then you have the manometry software tower in a separate room. So you're not able to calibrate the catheter because you basically have the catheter in when they're asleep, and then
I see what you're saying.
have to connect it to the device later and without calibration. So it's not fully recommended. Also, sometimes patients coming out of sedation can pull at the catheter, potentially damage it. So it's just not something that we did in our practice, although I do understand that people, elsewhere do. I would say as soon as the patient can tolerate and follow instructions is when you can perform your protocol. So it could be a while, you could be taking a PACU bed. That's again another reason why we didn't really do it. It's just very logistically challenging.
Okay, makes sense. Thank you. Are there any other less uncomfortable tests that can give information similar to esophageal manometry?
Yes. So manometry is considered the gold standard for diagnosing achalasia type conditions. So if we're suspect of achalasia, unfortunately, the manometry is on their radar. But for people with, other kinds of dysphagia, reflux, sometimes the physician can choose to perform an endoflip distensibility test, which is during an endoscopy. It's not the exact same kind of information as manometry. It's not looking at contraction strength. It's more looking at distensibility. So how is the esophagus like stretching and relaxing rather than how strong is the push. So, and it's newer technology, so there's not as much data on it. So some physicians are a little more skeptical of its utility than others, but usually we can see if an endoflip is normal, a manometry would be normal as well. And then of course the esophagram that I had mentioned earlier gives a lot of structural understanding of that a manometry can give us. It's not going to give us strength of peristaltic contraction or how well the LES relaxes. It's not going to give us exact numbers, but it can give us kind of an understanding of that. So that's another good option as well to always start with before going straight to manometry.
Got it. Okay. And how long do you usually slot your motility studies for? Like, how long does the procedure last, would you say?
So in our clinic, we would usually give an hour.
Okay.
Oftentimes, we would be doing a pH study on the same day as the manometry. So we would come in, we would prep the patient, get their consent, numb them, and then, just answer any last minute questions. Then we would do the manometry, which all in all maybe would be like, we would usually tell patients 10 or 15 minutes. Sometimes it would be 15 to 20, other times 30, it can vary. Then once that was over, we would then have to place a pH catheter. So that's why we always gave an hour, because then we had time to turn the room over, get clean up, and make sure the patient's questions were all answered before they would go home with a 24-hour pH study.
Got it. And when you talk about numbing, can you go over how, like, what protocol you guys use to numb or to help with pain?
Absolutely. Absolutely. So I had mentioned it in my pain management slide. We would use a benzocaine gel.
Okay.
And we would basically put the gel on a Q-tip and like move it around up in the nair to numb the nair. Sometimes we would even like pull it up in a syringe and like give them a big, squirt of it, let it simmer there for a little bit, and then they could blow it out. We would also spray the back of the throat with a benzocaine spray. Hurricane was the brand. It was like cherry flavor. It was really gross, but very effective. Would also kind of make the patient swallow and feel really strange. Some people would panic with that, so we would always warn them beforehand. Hey, this is gonna make you really numb. When your throat's numb, swallowing is gonna feel very different. So we want to make sure that they were aware of that, so they didn't think that they were having like an allergic reaction to the med.
Sure. Okay, but it does seem to help with the pain that you notice.
Yeah, I always tell people, listen, like it's gonna be uncomfortable no matter what. We're putting something where nothing should be going down a route that you're not used to having anything placed down, so you're gonna feel a level of discomfort. Sometimes it's gonna help with any soreness in the throat that's caused by the catheter. But there's patients that have done the test successfully without the medication. So if you don't feel comfortable taking the medicine, it's not going to be the end of the world. But we always want to try to offer anything that could potentially alleviate their anxiety and help them.
Of course. And are all the catheters the same size, or are there different catheter sizes?
So I always use the same size. I can't recall if other companies have a pediatric scope for manometry, because this is a test that some is indicated in some pediatric demographics. But again, I only worked in adults, so we did not have any varied size of catheters.
Okay, so it's the same size. Great.
Yeah.
And we have time for a couple more questions. What sort of preparation does the patient need to do the day before or the morning of? Anything they have to do beforehand?
Just morning of. There's no other prep required. Sometimes if we suspect the patient has achalasia, will elongate their prep, which is basically just having them on clears for 24 hours beforehand. But so if we suspect an achalasia type condition where the lower esophageal sphincter is too tight and things aren't passing through, then we would say prep with clears for 24 hours beforehand. And then 2 hours, I think, before we'd say nothing by mouth. But if it's just, your run-of-the-mill patient that we don't suspect achalasia, then it would just be clear liquids in the morning before the procedure. If it's an afternoon procedure, we would usually let them have breakfast before 10 a.m. And then clears up until 2 hours before, and then nothing by mouth within 2 hours.
Okay, great. And can this be done by yourself, or do you usually have another nurse or medical assistant in the room with you?
We always did perform these by ourselves in our clinic. We did have, other nurses on call just in case it was a challenging placement. We couldn't pass the NARS, we couldn't pass through the EGJ if, someone else wanted to come in and try. But usually as long as you're prepared with, your tape and your water, you can get the test done, just with one nurse in the room or tech.
Perfect, thank you. Okay, I think we are about out of time, so thank you so much. And I'm going to pass it back over to Tracy.
Thank you, Christina, and thank you, Allison, for that great presentation. We'd also like to thank everyone for attending today's webinar. You will receive a survey immediately upon the conclusion of this webinar. You'll be presented with the online survey, so please keep your web browser open, and we appreciate your feedback. For the CE certificate of completion, to obtain your CE credits, please type in www.saxtesting.com/INIT, register at the site, and complete your evaluation. And again, we'd like to thank everyone for attending today's webinar. We hope you have a great rest of your day. Thank you.